Good morning, everyone.
Good morning.
Good morning. No, how do you say that in Māori? Oh, ata Māori. Tēnā koe mo te kaupapa mo tēnei wiki te wiki tari o Māori, kia kaha tari o Māori. There you go. That's what we go. No, it wasn't that. It was just acknowledging the week is what it was. Look, I thank you for joining us, everyone. I'll make some opening remarks first of all, and then I'll highlight 4 specific programs, and then I'll take questions. I want to speak firstly to coronavirus. National is committed to responsible economic management through the COVID crisis. We have outlined our plan to invest in transport, education and infrastructure to stimulate our economy and build long-term productivity. We are committed to continuing to invest in better healthcare, education and public services. For health, New Zealanders deserve a health service that is modern, high quality, evidence-based and available to all, regardless of who you are or where you live. Our health policy will deliver better care sooner and closer to home. We will deliver more surgery, provide cancer care faster and fund Pharmac for more medicines. Even before coronavirus emergence, we were seeing cracks in our health system. Access to quality health care has slid backwards under Labour. Labour have spent more, yet many outcomes are worse. For example, every single one of National's health targets are worse today than when we handed them over in 2017, and Kiwis are missing out on care because of it. National is focused on ensuring more New Zealanders have access to world-class health care, regardless of income, background or postcode. We have practical solutions that will have a tangible impact on New Zealanders for generations to come. Our comprehensive health policy will be available on our website. Today, however, I will highlight 4 key elements that will allow for better care sooner and closer to home. These will include improving primary care, more elective surgery, more medicines and better cancer management. Firstly, though, I want to bring together the components of our coronavirus response. Nothing in recent history has brought about as much global disruption as the COVID-19 pandemic. Kiwis have sacrificed much through the restrictions of lockdown, and we can all be proud of our collective effort as a nation. However, there is more we must do. We must pursue relentless improvements in our border response, which cannot be let down by inadequate testing of border staff, and even today, Day 3 testing in managed isolation is still not compulsory. In our view, it should be. National will establish the unified Crown Agency to manage the government response to securing the border, the first and best line of defence New Zealand has against coronavirus. National will convene an immediate public health summit that will bring all aspects of our community together so we can all agree on what is best for the country. We will review the Pandemic Action Plan and build a public health workforce to ensure that all lessons are learned in case of future pandemics. We have already announced health policies that will touch many New Zealanders: a national methamphetamine program, cancer and children's dental health, and I will introduce 4 highlights from our health manifesto here now. The first policy to highlight are primary care navigators. With primary care navigators, National will change the dial on primary care, giving more tools to GPs and more services to New Zealanders. The first and most regular contact with the health system for many New Zealanders is the primary care team. Primary care and general practice is the gateway to secondary care and a key stakeholder in delivering care closer to home. More and more is being asked of GPs as a tsunami of need, including vital mental health need, makes its ways into clinics and primary healthcare teams are struggling. We will change the dial in primary care by fully funding a new addition to the team, a primary care navigator to all 1,000 general practice locations across New Zealand so that every GP has access to the skill set. The primary care navigators will bring a range of skills and could be somewhere between a social worker or a lived experience practitioner with an appropriate qualification. Communities will benefit by having a person who is part of their primary care team who can provide counselling, help unlock government agencies, follow up appointments and referrals, and do home visits. We back primary care and we will bring care closer to your home. Elective surgery. When New Zealanders need surgery, they need to know the public health system is there for them. Last year, 7,312 surgeries were promised within 4 months and not delivered on time. This meant New Zealanders languished on waiting lists with increasing pain and worry. We will keep our commitment to elective surgery. When people are given the 4-month commitment to treat from a DHB, that promise will then need to be kept, or the DHB will need to arrange for that care elsewhere. We will also remove the postcode lottery that currently aligns surgery with where you live and not who has the greatest need. We will have one national scoring tool and a national set of surgery levels so that access to public surgery is the same from Kaitaia to the Bluff. Funding Pharmac. National will fund more medicines for more New Zealanders. National will ensure that Pharmac is funded to deliver a wider range of medicines that New Zealanders need, ensuring better care sooner. We will ensure that those with rare diseases have a chance at Pharmac funding for medicine. We have a strong track record in funding Pharmac. When in government, National increased medicine funding by an average of 24 million per year. The consistent increases in funding meant that 800,000 more Kiwis benefited from access to medicine. Many Kiwis have expressed to us concerns over the range of drugs that Pharmac funds. This is especially the case for rare disorders. To achieve more access to more medicines, we have 3 key initiatives. Firstly, we will increase Pharmac funding by a minimum of the same rate as increases in the wider health budget, Vote Health. Second, we will set up a rare disorder fund with $20 million in funding over 4 years. Thirdly, we will set up a dedicated cancer drug fund with $50 million per year. Year on year, this will be more funding for Pharmac than at any time in the past decade, and New Zealanders will have better access to more medicines. Finally, cancer. We understand the urgency of cancer, and National will act urgently. The sad reality is that most New Zealand families will at some time be affected by cancer. Cancer doesn't discriminate when it chooses its victims, and all New Zealanders should have timely diagnosis and management, including the ability to access potentially life-saving drugs. New Zealanders shouldn't have to pack up their lives and go to other countries for cancer treatment. We will speed up the diagnosis of cancer by rolling out the delayed bowel screening program to the remaining 10 DHBs in our first year in office. We will also pilot a CT screening program for lung cancer, which will benefit particularly Māori. We will improve cancer treatment with a commitment to start building the delayed radiotherapy machines at Hawke's Bay, Taranaki and Northland DHBs in our first year of office. We will increase access to cancer medicines and form a cancer agency to oversee cancer management on a national basis. Urgency is important for people with cancer, and we will commit to moving urgently. Thank you. I'll take questions.
When it comes to fixing that postcode lottery, how do you do that? Is just standardising the point system, or is there a funding mechanism that needs to go alongside that?
Look, I think it's a combination of 2 things. Mostly I think it's having a unified scoring system so that you can score what's called the CPAC, Clinical Priority Access Criterion, which is the bar that says if you cross that level, you get surgery. And we know there's a range of tools across all the DHBs that set different bars. For example, if we look at orthopaedics, this is your hips and knees, access thresholds. How can it be that the threshold in Auckland is 50 and in Waikato, another large DHB, it's 70? Why do you need to have a greater need, more pain and wait longer in Waikato? That doesn't make sense.
Isn't the answer to that question funding? Because
No,
the systems are based on how many surgeries they can get through, aren't they?
The first part is based on having the same threshold and identifying the principle of equal need, equal service. Then there becomes a funding component, because Waikato may legitimately say, look, we're just not funded, we've set this level because we couldn't fund anything lower. That's, I think, the question you're raising, and we'll fund appropriate surgery through our elective surgery program.
How much will that cost to bring the equity up?
I'm sorry?
How much will that cost to bring the equity across the system up?
I'm certain on that, because our first thing to do is to prioritise and see exactly how much we've got on waiting lists and what priority everyone is. So a unified prioritising scoring tool is our first objective, and then we'll know what the funding contribution needs to be.
Overall, though, will National spend more or less than Labour on
National is spending what we're announcing here today. We're announcing $800 million in new funding. The point I would make is, and we'll need to see our fiscal plan to see exactly what our other commitments are. The point I made earlier on is that Labor have spent more on health, and yet I'd make the case have worse outcomes. And so we want to be smarter with health funding.
Your policy doesn't once mention the Heather Simpson review. Would you not implement any of the recommendations in it?
So there are some really good parts to the Heather Simpson review, actually. I quite like the proposition that we might increase some of the adjusters in the population-based funding formula, particularly for ethnicity and deprivation. So the fact that it's not mentioned here, don't take it that there aren't very useful components to the Heather Simpson report. I actually did like part of the weave-in of inequities actually through the Heather Simpson report as well. What I don't like with that report is we will not be reducing DHBs down to 8 to 12, and I think the government should be brave enough to go on the campaign trail and say which DHBs are not going to make it. If that truly is their line of direction, which is what they're saying, put that on the campaign trail.
And you wouldn't set up a separate Māori health agency?
No, we would not. We believe that if we can take Māori health strategy closer to the community, we're going to do a better job. And so we'll take that strategy right down to DHBs, make it an annual reporting strategy where they project what they're going to do in the year coming forward and are held accountable for their Māori health strategy in retrospect.
So if you were to be elected, that whole report would have been a waste of time?
No, not at all. First of all, it's an excellent data repository. Some really good resources and information in that report, which I go back to, and in fact I've used to inform some of these policies. So really good there. And as I've indicated to you, there are other suggestions in the Heather Simpson report that we would look at incorporating, like the changing to adjusters and PBFF.
Is $5 million a year for rare disorders anywhere near enough?
Look, in health there's never enough, actually, in health by itself or in medicines. But it was a commitment that we made in the 2014-15s with the $20 million rare disorders pilot, which was successful, though we would have liked to have used more of the money. Turns out we didn't use it all. And so we'll make sure that there is a sort of a use it or lose it. It needs to be used. It needs to meet its purpose. So no, it's actually never enough. But we need to remember rare disorders have several funding pools. They have the combined pharmaceutical budget. They have the exceptional circumstances framework, and then the rare disorders pool. So across those three, we're doing our very best to recognise that the Pharmac utilitarian approach of the greatest good for the greatest number of people doesn't quite suit rare disorders.
Setting up these dedicated funds, though, doesn't that interfere with the neutrality of Pharmac and its ability to look completely across the board at any situation?
No, I think in this instance we can give a signal to Pharmac, in fact, like we did in 2014-15, that rare disorders may miss out on the formula they use to allocate medicines. And that's what we're sending here, a signal that we think this group is missing out. There may be other groups that we need to look at as well, but this group clearly misses out, and we'd like to pay attention towards that.
Do you believe, Shane, could I ask you a question about your constituents in Northland? That how would the policies that you've outlined today improve the health outcomes of the people in your area, the far north, that we know are seriously lacking in access to health services?
Sure. So I think two of the policies that actually we've already announced are particularly impactful for Northland. If we look at the latest wastewater analysis of methamphetamine, unfortunately, Northland was top, and that's about 3 weeks ago that evidence came out. So our national methamphetamine program will have a big impact on Northland, particularly since they already have what I think is one of the best programs in the country Te Ara Oranga, which is Matrix Light. And we're going to fully fund a Matrix program, firstly. Secondly, turns out Northland children also have the worst dental caries. And our announcement yesterday of $30 million per year for a dental health program, Northland children will benefit from that. Of course, it was to benefit all of the country. It just turns out they're the top of the list for that. So those two announcements will have a lot of impact for people in Northland.
And do you see that extending to the rest of the rural areas in our country?
Yeah, we do. I mean, we have particular interest, as you'll see in our policies, in rural healthcare, and I want to acknowledge the hosts here today. We have a range of policies for rural medicine. I think one of our flagstone policies is understanding our workforce and the deficiencies we have in our workforce, particularly around general practice. It's really hard to find a GP, even in metropolitan areas, let alone rural areas. We know that 50% of GPs over the age of 50 will retire in 5 years. Oh, and by the way, their practice nurses are of an older cohort as well. So while we focus on GPs, let's consider the whole primary care team. And that's why we'll take out to RFP a proposal or seek proposals for a third graduate medical school with the mission of retaining general practitioners out in rural environments. It's a key leader for us. We're also really interested in tagging health data for rural environments. How can we fully determine the need of a rural environment if we can't see what their health services, how many health services have been actioned or been used? So we're interested in doing that. We're also recognising, certainly under coronavirus, those different models of care, the importance of health information technology. It's important here in a city, but out in a rural environment, it's even more important. Now, some of that sits outside the health portfolio. That'll sit under infrastructure, broadband, for example. But these are just some of the things. We have a range of policies in the detail that particularly recognise rural medicine and rural environments, and the extra needs that they have.
Are you confident that there are the jobs, there are the people there to fill those jobs for the primary care navigators?
Yes, we are. This really will change the dial. Just think about it. We're adding to the primary care team. And if you look at some of the environments overseas, for example, the NHS, where I've been fortunate to work, social workers or a social worker type person has been a key person in a primary care team. In fact, many of us figured out they were more important than us as the GP, actually. They were actually doing a lot of legwork. And they're the key agents for us taking that care closer to home. In fact, tell me any health need in the community that I can't start with, and that's why we have a primary care navigator who will, whatever need you want to express to me. This really changes the team, and I want to endorse or, first of all, acknowledge General Practice New Zealand, who'd done a lot of work on this actually, and we came together with a meeting of minds that brings this proposal forward. So I just want to thank them here now. To answer your question more fully, do I think there's enough workforce? Yes, we do, because the primary care navigator is something between a social worker and a person with lived experience, maybe with a level 4 micro-credential, something on that spectrum. Furthermore, as we look out the rollout, we're rolling out to a third in year 1, 2/3 in year 2, and then the rest in year 3. So it gives time for that workforce to build up. We think that's going to make a key difference to communities and to New Zealanders. You know, when I've been in practice myself and I look out at the waiting room and my list is full, the waiting room's full, and yet I've been flagged, I have a mental health consultation coming towards me. I know that's a 45-minute consultation, and yet look at my waiting room and I'm thinking, crikey, I don't want to be the one who misses a suicide patient. I need to be the one who does a really good job with this person, but look at my waiting list, look at my waiting room. Imagine if it could be that I did that initial triage, identified what the actions were, and then, you know, I'd like you to come next door to Belinda, and she's going to do a deeper dive with you. I need to understand better your work environment. I need to understand better your home environment. I need to understand better why government agencies have locked you out for reasons I can't explain. Come next door with me. It'll make a big difference. It'll help decompress what I've called that tsunami of need that is coming towards primary care.
Is access to medicine a human right?
Oh, that's a challenge. You know, to have rights has responsibilities by definition. I think access to medicines is absolutely critically important, but I don't know if it would quite sit as a right. I think it's certainly an imperative, but I don't think it's quite a right. We're doing our very best to increase that number of medicines, increase the access. And the statement I made is that year on year, we're going to be putting more money into Pharmac funding than any time in the past 10 years. And I think there's something interesting about guaranteeing Pharmac funding. Whatever Vote Health has gone up by, you can guarantee you'll get that minimum increase as well, on top of 50 million for cancer, on top of 5 million for rare disorders.
And just looking at all this funding, is this over and above funding cost pressures within DHBs, for example?
Yeah, so we'll fully... Well, it's a good question. We'll fully fund cost pressures, both demand and supply side, and that will be in 2 places, one in our fiscal plan and secondly in our unallocated operational spending. So we'll commit here to fully fund cost pressures, both supply and demand side.
How can you guarantee that 4-month wait time for elective surgery? I mean, is it built already?
No, what we're saying here is that if we send the right signal to DHBs and the right expectation, that they'll be able to meet that expectation. And the way to measure this is a tool that we introduced called the ESPFI, the Elective Surgeries Performance Flow Indicators. And if we look at that, we can see which DHBs haven't been able to meet their 4-monthly commitment, which, as I said initially, was 7,312. But if I just pick a couple of DHBs, for Tairawhiti, it was 23. Tairawhiti must be able to do another 23 cases in a year. Let's go to a bigger DHB, Capital and Coast. It was 63. Surely Capital and Coast can do another 63. So we think this is a very real and honest commitment that if we commit to you, your surgery will be done in 4 months, it's done in 4 months. And we think DHBs can do that. And raising to the point that was raised here initially, we all are prepared to fund that as well. So we don't want to set an expectation that's unreal, but we do want to keep our commitment of, we commit to you for 4 months, you have your surgery in 4 months.
What if the DHBs don't meet their commitment, they don't meet their targets?
Then the funding that goes with that surgery, they'll be responsible for either finding another DHB who can, or potentially a private provider. That will be the punitive consequence, if you like, of not meeting that commitment. We want to keep our commitments.
On COVID, is National committing to the elimination strategy?
Here today, we are committing to the elimination strategy. We continue to commit to it. We do understand, though, that over time, and as we see these cases continuing to grumble along, that may need to change, that it's somewhere on the spectrum from elimination to suppression. We also may need to rethink what our position would be on that. But here today, our position is supportive of elimination.
Shane, Aotearoa's 200 rural general practices would be heartened to hear about the primary care navigator, I'm sure. But one of the concerns I have is, and our members will have, is that whilst you want to retain the number of DHBs and the infrastructure that goes with that, as a rural DHB member, I agree with that. But the infrastructure to support primary care isn't there. There's a lot of onus being put on primary care, throwing an FTE here and there without being flippant about that and undermining the impact that that could have, is heavily reliant on the primary care infrastructure and funding models. How do you see that working through?
In further detail, we have a lot of commentary on primary care funding. In fact, if I look at the investment objectives of the portfolio, primary care funding, infrastructure and health workforce development, and that'll give you a clear indication of what we're thinking about there. So primary care infrastructure, primary care funding, we've actually allocated funding looking at VLCA targeting. We understand the paradox between VLCA and non-VLC practices. We actually put a couple of $1 million towards trying to figure that out. So primary care funding, if you look at the details of the policies, we do apply quite a lot of attention to that because we understand that parts of that are broken, and if primary care is broken, the whole system tends to break.
I guess the impact of that on a rural practice is greater because you haven't got the economies of scale that you've got in some of these larger centres and urban metropolitan areas. So, I mean, you know, you can have places in primary care and Kaitaia, the pressure that that's under.
Oh, sure.
And I keep going back to your constituent area.
Thank you. What I'd also be looking at doing, it's a very complex funding model for rural medicine. I mean, there must be 7 revenue streams at least, and I'm just wondering how we can sort of peel that down and make it easier and simpler. It's a piece of work we're thinking about, but yeah, we've got rural care, rural people in our eyesight. There was a question here.
Third graduate medical school. Wasn't there already a process for deciding that's under the old national government, and why not just go, didn't they have a recommendation, I think, for where it should go and how it should get it?
That's right, that was cancelled by the Labor government, if you recall, and so it was a proposal. In fact, we had it in the 2017 campaign trail under Bill English that we were interested in a third rural medical school, or a medical school focused on retaining practitioners in rural environments, actually. So yes, there were some indicative business cases done. There were proposals from Waikato, there were proposals from Auckland and Otago. We want to review that process, start off from where they left it and look at it again. What is your offering? Here's our need. Here's what we want to achieve. What can you or any other tertiary institution in New Zealand offer to meet the need that we have? So yes, we would pick up from where that was left off.
On your cancer policy, is that over and above the 7.5 million that went into the cancer agency under the government?
Yes, it is. What you're seeing here is new program funding. In fact, just for those who are noticing, there's nothing here on mental health and disability. There'll actually be separate announcements, mental health, next week. Why I raise that is because we'll be keeping the mental health funding as well. That's why I mentioned that.
The rare disease fund, what kind of disorders do you see being funded out of that?
Well, there's a definition for a rare condition, and I think it's rarer than 1 in 60,000. So that actually defines what the condition is. And if we look, I mean, I'm not going to identify particular clinical conditions here because it needs to meet that criteria. But what we did see with the previous pilot was that only about $2 million of the funding was consumed, and I think about 10 new medicines came from that whole funding stream. We want to use all of those funds and reach out a lot further. Not clear to me why we didn't use it all, not clear to me why we only got 10 from it.
But the pilot failed?
No, the pilot could have been, it was a pilot. You learn from pilots and then decide whether you ramp it up, that's why it's called a pilot, ramp it up into a full implementation. So I think we'll learn from that pilot and make the next entry better. That pilot in 2019 was subsumed into the combined pharmaceutical budget by the current government. It just stopped.
You
One of the-
do
one of the
insist on that
conditions
money
that
being
they-
spent though, don't you risk that money being wasted?
No, I think if we set clear parameters, I mean, who couldn't think of a medicine that would be better spent for a rare disorder? And so I think that's just a feature of what the prioritisation criteria are, rather than money being wasted. We wouldn't want to just use it for the sake of using it. That's not what we're going to do.
So one of the conditions that people have been crying out for is spinal muscular atrophy, a drug called Spinraza that would cost $6 million annually. Your fund isn't going to cover that.
And so that question would be, would it sit in any of the other two funds? Would it sit in the combined pharmaceutical budget, or would it sit in the exceptional frameworks bucket? Or would there be some part of that the Rare Disorders Fund might fund? That sort of detail is a question we're going to leave with Pharmac. They need to figure that out.
New Zealand is suffering right now. That, your fund doesn't cover it.
I am familiar with the condition and the physiology as to how the medicine works. We are making a contribution towards all rare disorders, and if that meets criteria, then we'd be pleased and privileged to be able to help if we can.
Do you expect the closure of borders and economic turmoil to affect the cost of these medicines that Pharmac is requiring, and does your funding increase get ahead of that?
Yeah, that's a really good question, because we know the logistics chain for pharmaceuticals has been significantly affected during coronavirus. And in fact, if we look at the withdrawal of one of the major players, the Pharmac players, who had about 60 medicines, as I recall, in New Zealand, their withdrawal from the New Zealand market talked several things to us. First of all, the sole supply principle that Pharmac has. We got caught a bit short by having sole supply when this supplier took their medicines offshore. And then, of course, the coronavirus logistics chain slowed things down as well. So to answer your question, could medicines be more expensive? Yes, they could. Pharmac are very good at managing that, but yes, they could. We're putting more money into Pharmac. Whether that's going to be enough, we'll see as we make our way through coronavirus. What I would like to point to, though, and because it interests me amongst other things, one of the Pharmac proposals here is exploring a drug reuse policy. Now, if we look overseas in 38 of the US states, drugs that are unexpired and unopened can be returned to a pharmacy or a medical facility and redistributed for those who are vulnerable or otherwise couldn't afford it. We're interested in exploring that, a drug reuse facility, and you'll see some funding put aside to explore exactly that. The NHS had been less enthusiastic to adopt it until coronavirus hit, which talks to your point, and as their logistics chain slowed down, suddenly they decided, maybe we could reuse medicines that have not been opened, untempered, and are unexpired. And so I believe from some of the rest homes, they looked at reusing some of those medicines forced into a new model of supply by coronavirus. And so you'll see something here about exploring medicines reuse like other countries are doing, whether it's something that would work in a New Zealand environment.
So you're committing to more medicines regardless of how the logistic chains are affected?
Oh yes, I think the amount of money we're putting into this here should counter that, yeah. Good. Okay, I think we're done. Thank you very much for your time.